is the exploration of the peaceful end of life theory. It's for Nursing 5120, theory-oriented nursing practice. I'm Christina Hastings. This is Amanda Applegate and Brent Blackburn.
The background of the theorists that contributed to the peaceful end of life theory, the first theorist was Cornelia Ruland. She attended Case Western University in Cleveland, Ohio, and received her PhD in nursing in 1998. Shirley Moore also attended Case Western Reserve University in Cleveland, Ohio, and received her PhD in nursing science in 1993. The development of the theory together, they derived their theory while Moreland was a faculty and Ruland was one of her students. The theory was developed from a standard of care with the goals to express a fresh, uniting awareness about the occurrences of the peaceful end of life, to resolve previously unanswered uncertainties, to give new understanding related to the phenomenon, and to create an adequate and appropriate framework that encompasses all facets essential in the care of patients that are terminally ill. Mid-range theories, they are specific to the situation, they're client-specific to the population and age, they're location or practice area specific, they're nursing intervention specific, and they're anticipated patient outcome specific. Middle range theories provide a framework for interpretation of the specific phenomenon. They offer guidance related to nursing interventions, and they can be generalized beyond the specific location, time, or population. The practice experiences of each theorist will be discussed. Ruland is the director of the Center for Shared Decision-Making and Nursing Research at Rikshospitalet University Hospital in Oslo, Norway. She also serves as adjunct faculty at the Department of Biomedical Informatics at Columbia University in New York. Moore is the Associate Dean for Research and Professor at the School of Nursing at Case Western Reserve University. She's taught at various levels in the nursing programs and coordinates a research and theory development program specifically dealing with recovery after cardiac events. As far as theoretical sources, several sources were used into the formation of their model. Donna Bedian's model of structure, process, and outcomes was used. The structure in the peaceful end of life theory deals with the terminally ill patient and his or her family members. The process refers to the nursing interventions that focus on making the end of life experience as peaceful as possible for the patient and the family members. The outcome is the positive expectation that you expect to see as the result of the interventions that are performed by the nurse. The preference theory was also used. The preference theory was used to describe getting what one wants as the good life. It was utilized to clarify and describe quality of life. Quality of life was described and assessed as an appearance of satisfaction through observed assessment of outcomes specifically expected with comfort at the end of life. As far as the contribution to empirical evidence, experience of expert nurses that each had at least 5 years of experience in clinically caring for terminally ill patients. Each one of these members that contributed to the theory had some clinical experience with this type of patients. They also did a thorough literature review regarding the relevant concepts within the theory. They wanted their concepts to be as clear and observable in regards to caring as they could possibly get them. The primary source for this theory is entitled Theory Construction Based on Standards of Care, a Proposed Theory of the Peaceful End of Life. It was written by Ruland and Moore, and they gave details regarding the development of the theory and the concepts behind the theory within this document. The nursing paradigm, the 4 elements are addressed within the theory. The client and the person refers to the terminally ill patient and his or her family. The environment refers to the surroundings of the patient, typically a hospital, home, or long-term care facility. Health is describing, it's not so much a focus on the absence of illness, it's more a focus on quality of life. And according to this theory, health is measured by 5 outcomes. These 5 outcomes are not being in pain, experience of comfort, experience of dignity and respect, being at peace, and closeness to significant others. Nursing in this theory refers to the interventions that are implemented in order to meet the 5 outcome criteria. The major concepts and definitions within the theory: not being in pain. Ruland and Moore describe not being as pain as the patient actually not experiencing pain, not having those unpleasant sensory or emotional experiences. The experience of comfort, they state, is relief from discomfort, the state of ease and peaceful contentment, and whatever makes life easy or pleasurable. The experience of dignity was defined by Ruland and Moore as being respectful and valued as a human being. Being at peace was defined as calmness, harmony, and content. Feeling of closeness. Ruland and Moore, in this feeling of closeness are referring to a feeling of connectedness between the patient and his and her family members, or the individuals that are also giving the care to the patient. Major assumptions. There are 3 major assumptions that are noted within this theory. The first one being that the end-of-life experience is unique and personal to the patient. The authors have assumed that each patient has the same perspective regarding death. The next assumption is that nursing care is of extreme importance. They assume that the client wishes to have the aid of the nurse during the experience. The third assumption is the nurse can interpret the signs or symptoms of distress or discontentment or contentment. The authors have assumed that the nurse is capable of making this decision of determining whether or not the patient is at peace. There are 6 theoretical assertions that are noted within this theory. The first one is dealing with the patient not experiencing pain. The nurse addresses the patient's perception of pain. The nurse monitors for signs and symptoms of the patient's pain. The next one is comfort. The nurse deals with this in prevention, alleviation, and by observation. The next theoretical assertion is dignity and respect. Decision-making process helps to go into this one, especially involving the patient's family members in the decision of care. That helps to the patient to feel more dignity and respect. The next one is the patient actually being at peace. The nurse tries to offer emotional support, trust, and guidance in these decision-making processes, and giving the patient as much information as they can as far as education and just a companionship in the nurse and being there for the patient. Closeness, again, in alleviating grief and answering questions and allowing bonding opportunities between the patient and the family members to encourage the family member to be there for the patient. The culmination of these 5 elements is the 6th theoretical assertion, because all 5 of those must be present in order for the theory to be carried out. In summary, the peaceful end-of-life theory, it serves to provide nurses caring for terminally ill patients with a framework to guide nursing care and to stimulate the development of new research, new knowledge through research. There's one last summary of the concepts. They are all interrelated. They all have to be present in order to have the peaceful end-of-life experience. And each concept is interdependent on the other.
The following is a schematic model of the theory of the peaceful end of life. And this schematic model was based on the Ruland and Moore's text, Theory of Construction Based on Standards of Care, a proposed theory of the peaceful end of life. And under this schematic, we have the 5 concepts that consist of this theory. The first, not being in pain. And as previously stated, this concept is defined as this patient not experiencing pain in an unpleasant sensory or emotional experience. And to alleviate this, the nurse monitors and administers pain relief, applying pharmacological and non-pharmacological interventions. The second concept is experience of comfort, and Ruland and Moore define this as a relief from discomfort. They accomplish this by preventing, monitoring, and relieving physical discomfort, facilitating rest and relaxation and contentment, and also by preventing complications. The third concept is experience of dignity and respect. This is defined as being respectful and valued as a human being, including patient and significant others in decision making, treating patient with dignity, empathy, and respect, being attentive to the patient's expressed needs and wishes, also his preferences. The fourth concept is being at peace, and this is simply described by Ruland and Moore as a state free of anxiety and worry. Providing emotional support helps alleviate this. Monitoring and meeting patients' needs for anti-anxiety medications. Inspiring trust within the patient. Providing patient and significant others with guidance and practical issues. And the last intervention is providing physical assistance for another caring person if desired. The last concept is closest to significant others who care. The nurse addresses these issues by facilitating participation of significant others in patient care, attending to significant others' grief and worries, and by facilitating opportunities for family closeness. Logical form is the purpose behind concept is not dying itself, but rather a contribution to peaceful and meaningful use of time remaining. This logic was interpreted using inductive reasoning as well as deductive reasoning. Inductive reasoning being defined as by Applegate and Zomi as a form of reasoning in which generalization is induced from a number of specific observed instances. The authors determined it necessary to develop a concept for terminal patients who value their time, being that each terminal patient had some identifying relationship. Deductive reasoning was defined by Applegate and Zomi as a form of reasoning where specific conclusions are inferred from more general premises. Terminal patients value their time, is what Ruland and Moore established as deductive reasoning. Logical form contributed to nursing by expressing new ideas and answering questions. The flaw to this theory is that it does not address terminal patients who have not accepted that death is approaching. For example, the theory does not acknowledge patients who are in denial.
Okay, the relationship of this theory to nursing research. The concepts of experiencing a good death and a peaceful end of life have been used synonymously. There's been very little research specifically on the peaceful end of life theory, but Beckstrand, Callister, and Kirchhoff performed a survey of critical care nurses' suggestions on improving the end of life care. And these suggestions, a lot of the suggestions are represented in the end of life theory. Kongzawan performed a study to describe the concept of a peaceful death in relation to cultural and religious beliefs, and this study was done on Buddhist culture and religion. The end-of-life education is also necessary in transitioning the nurse's inherent need to actually keep the patient alive, which is what a lot of nurses focus on. You have to transition that to aiding the patient in experiencing a good death. Esper, Lockhart, and Murphy explored the adequacy of nursing curricula related to end-of-life care, and the study found that end-of-life care comprised less than 1% of the total curricula content. In an effort to reach an increased end-of-life education, in 2011, researchers began a project titled the End-of-Life Nursing Education Consortium. And this was developed to provide leadership in palliative care, to educate advanced practice nurses to provide leadership in palliative care, and to increase the expertise of the nurse in the end-of-life care. Some suggested that APN involvement could actually assist in coordinating the interdisciplinary team, coordinating the healthcare team. Implications for advanced practice. The end-of-life theory can easily be adopted by the advanced practice nurse and utilized to provide care for end-of-life. And it does provide a simple framework of standards of care. For the hypothetical scenario, we'll be focusing on utilizing the framework in the nursing care of a patient that's terminally ill, and focusing on those positive outcome criteria established by Ruland and Moore. Mr. Hamilton is admitted to the hospital. He's terminally ill. He's got cancer, and he's already accepted, that his death is imminent, and he is, DNR. But his family is having some difficulty coping with his death and his health status at the time. They're having difficulty in the grieving process. He reports a decreased appetite. He's been increasingly lethargic over the recent time, and requires full assistance in his ADLs. He rates his pain on a scale of he rates his pain as an 8 on a scale of 0 to 10. To focus on pain, first of all, the nurse encourages Mr. Hamilton and his wife to make suggestions on methods of pain relief that they've used in the past and what's been effective. So they suggest playing soft music, repositioning him in bed, maybe putting some more pillows in the bed. Mr. Hamilton asks his wife if he could massage his back for him. And the pain, after making these interventions, the pain's decreased to a 3. And then the nurse decides to go ahead and give him some pain medication, because we want to reach the goal of being at a level of 0, experiencing no pain. So the effect, after the medicine takes effect, he does reach the outcome criteria of experiencing no pain. The nurse incorporates the family and the patient's wishes in the plan of care, and this addresses dignity and respect. The nurse asks Mr. Hamilton's suggestions. If the family wants to help with his bathing or ADLs, the nurse encourages that to maintain his level of dignity and respect. Mr. Hamilton is aware that some of his family members, especially his son, is having a difficult time coping. And when his son comes and visits, he experiences some anxiety, and the nurse tunes into that cue. The nurse provides additional support to Mr. Hamilton and his family. She provides literature on the grieving process and helps the family better understand what to expect in the dying process. And this helps focus on the criteria of just being at peace, creating that environment, creating a relationship with the patient and the family. The family does assist, as I said earlier, in ADLs, and this affects the closeness to outcome criteria. Mr. Hamilton does need to be around his family, and we want the family to actively participate in his care. In summary, the peaceful end of life theory is a middle range theory that's applicable to terminally ill patients in an acute care setting. It's aimed to promote quality of life rather than the state of physical wellness. And this theory has uncomplicated terms, but the outcome criteria is abstract while the relational statements are complex, and this could reflect the reasoning behind there not being very much research specifically on the end-of-life theory. But end-of-life care is relevant in nursing care, and research and development of end-of-life care will provide a foundation for evidence-based nursing practice. And that concludes our presentation. Thank you.